Assalamu alaikum. I'm Dr. Shahzad. I'm one of the emergency medicine residents in the US. I have other board in Qatar board in emergency medicine, and I have fellowship in emergency medicine from Royal College of Emergency Medicine. Today I'm going to talk about delirium in patients who are coming to the emergency department. Most important thing, delirium is not an isolation diagnosis. So delirium always triggered by something. So try to look for the trigger, which is the most important thing. Delirium and dementia, you should know how to differentiate. So delirium is an acute change in your mental status accompanied by waxing and waning conscious status. So patient can be sleepy, can be drowsy, can be awake, and then can again go to sleep. But on the other side, dementia is a chronic ongoing process with no change in your conscious level. For delirium, it is usually happening in old age patients. The most common trigger for delirium is urinary tract infection, but it can be because of anything, either infectious, either traumatic, due to medications. But broadly, these are the most common reasons for delirium. Again, if there is a patient who is coming with acute change in mental status, look for the trigger for delirium. Okay, like don't label it as anything which is like more going towards the psychiatric or the psychological part. Yes, it can be, but acute thing which is like acute change, like within 24 hours or within 6 hours, 8 hours, a patient has started shouting, is behaving odd or is violent, so this is delirium. Okay, delirium is always caused by any trigger. So look for the trigger, look for the infectious source, do blood culture, urine culture, check for signs of infection, look for any signs of trauma, probably do head CT. Treatment for delirium, avoid benzodiazepines. Avoid benzodiazepines because it will exacerbate delirium. Go for atypical antipsychotics, maybe risperidone. You can use haloperidol, but essentially if you give haloperidol, then you have to think of giving some diphenhydramine just to balance the dystonia or any extrapyramidal symptoms. Delirium, if you treat the underlying cause, delirium will start to get better. Sometimes even with urinary retention, people can come with delirium. So just try to do a comprehensive head to toe assessment. Once you have done head to toe assessment and you have done your lab workup and you have find the cause, then you will start working on the cause. But at the same time, you need to manage patient with delirium. So hyperactive or hyperactive delirium can be of two types. So you need to manage accordingly, but avoid benzodiazepines. Hydrate the patient. Simply dehydration can cause delirium. That is one of the other common sources of delirium. And I think that's it about delirium. But it's kind of a common thing that happens in old age people, and which comes to emergency department. So try to manage it accordingly, and don't try to label it as a psychiatric illness. Obviously, disposition depends on the underlying cause and the overall patient progression. But that is it for now. Thank you so much, and I hope it is a learning point for you, and I'll come back with some other learning points and knowledge for you. Thank you.